So good morning all. I'd like to thank Varshini for organizing this wonderful IC and inviting me as well. So what I'm going to talk about is swollen disc in children, evaluation and management. Let's start with the case. A routine checkup child reported to us. Now carefully look at the discs. When you see the elevation is confined to the disc vasculature is visible at the margins, no venous congestion, sharp peripapillary nerve fiber layer reflex, crescentric circumpapillary light reflex, and no exudates. So this is a pseudopapilledema. Then when you see a patient like this, get a good B scan done, will show calcific deposits, showing high spike on A scan, a confirmation on CT scan telling you that this is a disc drusen. In addition, a fundus autofluorescence will also show this calcific, and as she described, this is a buried disc drusen. Sometimes you find those white particles outside, which is a thing which has come out. So when you have something like a disc edema, you need to classify it into asymptomatic, which is the pseudopapilledema as shown, or a symptomatic, which is seen here, where there's either a reduced vision, pain on eye movements, reduced color vision, headache, transient visual obscuration, which will give us a differential diagnosis of optic neuritis, papilledema, systemic or neurological diseases. So let's then understand what is true disc edema. When the elevation exceeds into the peripapillary retina, there's graying and mudding of the peripapillary nerve fiber layer and obscuration of the vessel just at the margin. You know that's a true disc edema. So then let's look at this case, bilateral disc edema. Both eyes had 6/18 vision with pain on movement. 3 days later, the vision improved to 6/6, had received vaccination 15 days prior. This is a classical bilateral optic neuritis. And look at the history. Vision loss, came back to normal and had vaccination. This is what is classical in children, which is different from adults, where it is painless, bilateral and anterior. It's associated with infection or post-infectious and unassociated with multiple sclerosis. What are the other features? Retroocular pain, severe loss of vision, even lack of light perception can be there. A classical relative afferent pupillary defect if it's in one eye. Less contrast sensitivity, that's the earliest sign to get affected. Then brightness sensitivity is affected, and color vision defects, which are basically washing out of your colors. Your red colors become less red, and that's important. So how do you classify them? One is infectious or non-infectious. In infectious, we're looking at rubella, measles, multiple of these infections that's mentioned, toxo, TB, and vaccination, which is live attenuated. This is classically said that if you have a post-infectious optic neuritis, it may be a harbinger of MS in children. The other are non-infectious, basically multiple sclerosis, ADEM, and Devick's disease. These are pediatric optic neuritis associated with neurological signs. So how do you investigate? A baseline MRI of brain with and without contrast, and with contrast is mandatory to pick up any enhancing lesions. If scan is normal, sequential follow-up is needed. But if scan is abnormal, as you can see, 2 or more typical white matters, offer treatment with IVMP. And if you have this classical presentation, we are thinking of MS. You may also now do aquaporin for antibodies and anti-MOG antibodies for specific conditions, which I'll talk subsequently, and other ancillary tests. Remember, LP has no role in this unless, because in case of an isolated, unless you're trying to classify the presence of MS by looking at oligoclonal antibodies. This is a classical criteria for MS. Role of steroids, no control trials for children as per whatever is an ONTT, but you can give IV methylprednisolone as mentioned. Maximum dose should be 1 gram per day, followed by a slow taper. Remember to maintain the taper very slow to avoid relapse. CNS involvement may require IVIG and plasma exchange. And this is the treatment for pediatric MS. But I usually collaborate with my pediatric neurologist for treatment. As mentioned, the other types of demyelinating, which are now more commonly seen, the NMO and the MOG IgG associated disorder. As you can see, neuromyelitis optica is a bilateral, simultaneous and sequential condition where there is aquaporin Ig antibody as a main marker, needs IV corticosteroids and rituximab, has poor recovery. On the other hand, MOG IgG, which is more common in children than in adults, is what we initially thought as CREON, has MOG IgG cell-based assay positive and needs treatment with IV corticosteroids, having excellent recovery. Now let's look at this case. A case with bilateral esotropia with bilateral 6-nerve paresis. We are looking at the disc, which is very important. Never miss your disc when you're doing a strabismus examination. This patient had early papilledema. It was basically a 6-year-old with headache and vomiting, referred to rule out papilledema. Vision, as you see, is not affected. Color vision is normal, unlike what we saw in a patient with optic neuritis. So this is early papilledema. So carefully notice your discs when you have a patient presenting with esotropia. These are established papilledema as it sets in, eventually chronicity, and finally atrophic. In atrophic, you'll see pallor completely come in and disc flatter. But that doesn't tell you that it's improving. In fact, it tells you that the vision is eventually going to go away and the child is going to be blind. So the failing discs are what appears when they start flattening. So we have to look for causes of elevated intracranial pressure, which could be intracranial mass, obstructed cranial venous flow, decreased CSF outflow, that is pseudotumor cerebri syndromes, and excessive CSF production. Symptoms are headache, transient visual obscuration, very, very important, you can ask, but sometimes difficult to elicit in children, nausea, vomiting, diplopia. So how would you investigate? Classically, vision, color vision, and visual fields where you have an enlarged blind spot, an inferior nasal step, which you can do only in older children, eventually constriction, and then the central field is lost. But what are the issues with the young children? Symptoms are unreliable. They may not complain of loss of vision and fields, uncooperative child, difficulty in doing an examination like vision, color vision, fundus, not able to do any of the OPD tests like visual fields. Sometimes they don't even have papilledema, infants with open fentanyl. So how do you confirm that your disc edema has anything to do or what the diagnosis is? For that, what I recommend is a B scan for optic nerve head size in SAF, where if you do a B scan of the cross section of the nerve, what you will see is this crescentric black hypoechoic crescent, which is classically with a diameter of more than 4. So here it's 6.5, indicating that this patient has papilledema. In fact, it is this SAF around the nerve that helps you differentiate it from pseudopapilledema and bilateral optic neuritis. And why do you see the SAF? Because you know clinically that once the CSF is formed in the lateral ventricle, goes to the third ventricle, then the fourth ventricle, it goes into the SAF space. And this SAF space, as you can see, is right around your optic nerve. And this is what you actually detect when you are doing your B scan. So the diagnosis or the cause for your papilledema is picked up by looking at this SAF. Then you need to get an MRI done to rule out the mass, because that could be one cause, and ventricular involvement of hydrocephalus, which is commoner in children, as you can see here. MRV for venous thrombosis, and finally LP for opening pressure. So here we do LP for detecting the opening pressure. We also do the analysis, but usually it is normal. Now when the opening pressure is more than 250 of, that is borderline, but definitive is more than 280 millimeters of water, you confirm that the patient basically has a pediatric IIH. And now I will talk to you about what will be the possible medical and surgical management of the same. But before that, let's understand why is IIH so important. Because it's a direct association with visual loss. It can cause irreversible loss of visual function, that is acuity and loss, in as high as 40% of children. And it can be the only serious complication which can occur early and late. And unfortunately, in children, we may not detect it till the child goes completely blind. Because as the vision starts coming down, they start adapting and they will be comfortable because they'll not be able to explain. So this is important. So how do you manage it, medically or surgically? In medical, weight loss for obese children. Diet is low sodium, corticosteroids in inflammatory conditions, and acetozolamide or furosemide to be given with serial lumbar punctures. This is done twice weekly, but not very suitable in children. Sometimes they spontaneously also resolve, but you need to monitor this. Now, we have published a paper where we've shown this monitoring treatment only on the basis of B scan, where the patient was started on treatment, and as you can see, the B scan showing the SAF resolved in 3 weeks of treatment. So here we cannot repeatedly do an MRI to see if there is a fluid behind it's gone or not, but this will tell you, yes, by the time the papilledema resolves, it's fine, but sometimes papilledema takes longer time to resolve. The fluid behind has disappeared, you know that the condition has resolved. So we basically have about 52 cases that we have been done with my pediatric neurologist from MSH Bangalore in Narayana Health City. We start with 25 milligram per kg per day, increase up to 40 milligram, monitor electrolytes, usually have got no side effect except for paresthesias. Topiramate to be added in teenage adolescent girls. Advise weight loss, very important, and that is more common in those which are in puberty, closer to that, and need a consultation with dietitian. And we had 1 LP done so far in fulminant IIH in 17-year-old and 1 optic nerve sheath decompression in a child. That brings us to the question, what is a surgical intervention? 20% needed, as mentioned, LP shunt or VP shunt. And ONSG has to be reserved for those where we are expecting visual loss or we are knowing the child is going blind. CVT is kept in conditions of those, anticoagulants are given. An intracranial tumor, surgical removal is a must. But you need to monitor the optic nerve, saying that the papilledema should flatten after this treatment. So how do you do it? Do an ONSD, do a 270 degrees peritomy, hook the medial rectus muscle, pass sutures through it, you disinsert it and take the baseball stitch, as you can see. Then turn the globe laterally, and here this is the medial transconjunctival approach, where you see the optic nerve sheath there. You take a direct nick into it, you will see the gush of fluid. After that, there's a decompression, then take a part of it out like a small window, put in a blunt instrument, try to break the connection so that the nerve, because if these are in chronic cases, they're multiply loculated. This is then followed by closure, middle rectus muscle is put back. And a patient who has an optic disc edema like this can get complete resolution by 4 months in something like this. So what is the best treatment in IIH? We can see that for resolution of vision, optic nerve sheath gives about 67%, but there is no perfect treatment because no trials have been done and no treatment guidelines. So we may need a subsequent retrospective study to diagnose the same. And then coming to the other causes of disc edema, neurological, you could have hydrocephalus, neurofibromatosis, spinal cord tumors, or subacute sclerosing panencephalitis. In systemic, we are looking at any of these, like for example, infiltrative like leukemia or lymphoma. You need to have a very good history taken prior to this, or somebody who's on follow-up needs an immediate treatment with oncologist, or shaken baby syndrome, as Dr. Varshini mentioned, especially an history of trauma to see, and then you may see these classical rot spots, which are typical of this kind of injury. So to basically summarize, when you have a patient with optic disc edema, find out whether it's true edema or pseudo disc edema. Once you've ruled out pseudo disc edema, for true disc edema, important to look for vision loss. If there is vision loss, yes, papillitis is what you look for, and go ahead and evaluate. But if there is no papillitis and there is no loss of vision, then you have to do an MRI scan to rule out structural and non-structural cases. In no structural cause, get a lumbar puncture done and the opening pressure to be checked to confirm a pseudo tumor cerebri. And if there's a structural disease and presence of high lumbar puncture, we are diagnosing as papilledema, we'll need a neurosurgical intervention. But if the lumbar puncture is normal, then we have to look at other causes. So 3 important P's that you have to note: pseudoedema, rule out, unnecessary investigations to be avoided. Papillitis, you need to treat it differently, and papilledema to treat along with, basically you'll need a pediatric neurologist to go ahead and treat your conditions.